And so I'm delighted for our third session today to have Dr. Dominic Harrison, the Director of Public Health at Blackburn and Darwen, to talk to us about improved health outcomes from all public sector activity. Dr. Harrison has worked in Blackburn and Darwen for some time. Previously, he worked at the Department of Health in the North West region and at the National Institute for Health and Clinical Excellence. So welcome to you, Dr. Harrison. Thank you.
Thank you. Right. I want to talk a little bit about some theory and then get down into some very nitty-gritty practice. But what I'm going to tell you is not that I or Blackburn with Darwen have got all the answers. I'm really going to report back to you where we are. I mean, it seems to me that this conference is symbolic of where the health and social care system is at the moment. It feels a bit like the Grand Bazaar in Istanbul outside these curtains, with everybody trying to flog you the answer to a slightly different definition of the problem. And it's all a bit confusing and overwhelming, and I think that's probably a very accurate representation of where we all are at the moment in terms of defining what we're trying to do. What I want to cover from a public health perspective is what I see coming into local government as a Director of Public Health, looking at issues of integration and trying to see where some of the most important interventions may make a difference to both improving health and reducing adult social care demand. This slide is probably the most important in what I'm going to say, because if you don't get this, you're not going to get, I think, what some of the challenges really are. And the challenge is that really most of what constitutes health intervention and most of what constitutes social care intervention doesn't come with either of those two labels. So this is looking at two of the most iconic indicators in the NHS in terms of health outcomes, life expectancy at birth and infant mortality per 1,000 at birth, and it's looking from 1900 right through actual data to a projected date of 2023 in the case of life expectancy at birth. And if you follow the improvements that have been occurring in the top one for both men and women, what you see, if you draw in your mind a dotted line up from 1948, you can see that actually the institution of the NHS makes absolutely no discernible difference to the improvements in life expectancy at birth that were already happening. If anything, the institution of the NHS, in the case of infant mortality in 1948, reduces the rate at which improvement was occurring before the NHS started. Now, there's lots of complex reasons for that. And one of them really is that health care services, as the Audit Commission commented on when it was reviewing England's failure to deliver reductions in health inequalities, the NHS can actually only affect between 15 and 20% of the mortality differences we observe in a population. In other words, 80% of what's determining good health, long life expectancy is nothing to do with healthcare system intervention. So this becomes really important in the kind of debate we're having around integration if we want to reduce adult social care demand and improve health outcomes. In a district like, so a lot of you will have seen Public Health England's information out yesterday, Blackburn with Darwen in deaths under the age of 75, all of which are generally considered preventable, came number 8 in the UK. But there is a 8th worst, in the UK, 8th worst life expectancy. One of the paradoxes, though, is we've increased life expectancy faster than at any time in the last since life expectancy was recorded. The last 10 years we've done better than at any other time. And in fact, we're now at a point where every 24 hours, I mean, this is not just in Blackburn with Darwen, your own boroughs will have similar figures, we're increasing life expectancy by about 7 hours for men and about 5 hours for women. So we're doing better than ever, but relatively some areas are doing worse. In a place like Blackburn, a northern industrial area, it's actually quite instructive to look at what the history of not just public health but actually councils was. 1851, town council established. Many councils were started around those times. Their first actions were to enable, through the Poor Law, a union workhouse, a sort of welfare system. Did this locally. They built 30 miles of sewers with 1,000 unemployed mill workers laid off during the cotton famine due to the American Civil War. The council put the money up, did that. They privatized water, gas, fire, burials. They took over private firms that were providing water, gas, fire, burials and waste, and took them into council control, improved them and handed a lot of them back. So that magic 50 years, councils had a lot of confidence. A lot of the money to do that wasn't from central government, it was raised by public subscription. It's interesting to see how councils might have lost some of their confidence in some of those measures. Of course, we fast forward to now, and we've got a recession. Now, this recession, we haven't seen the impact of this yet. Cabinet Office did a review in 2009 of the literature on recession. What evidence was there of recession impacts? And they said there were 3 waves. We're currently in wave 2, where we're seeing increasing family stress, more mental health problems, increase in domestic violence, rising alcoholism and addiction, rising crime, homelessness, etc. All those things are going to generate increased health and social care demand, and perhaps quite a lot of the discussions that are going on now around A&E in the NHS are actually related to predictable effects from the evidence. This was commissioned under the Labour government, is no longer available, as I understand it, on the Cabinet Office website, but that model, I think, tells us that things are going to get a lot worse if we've got financial austerity before they get better, however good our redesign of systems are, because demand is rising. We can see this, for instance, when we look at the data for, this is a pre-welfare reform, incapacity benefits for alcohol-related dependency. Many of the areas of increasing deprivation have higher rates of alcohol-related problems being the prime cause of their being out of employment due to having a long-term disability. We're also now seeing a massive impact as the cuts to the poor, particularly the poorer boroughs, hit, and particularly hit families with children more than anyone else. We're seeing a rise in mental health problems, suicide being the sort of final worst expression of that. But actually a lot of what's going on in A&E is about that. The evidence for that is getting stronger internationally. One of the consequences of this, and this does affect this debate, is we're talking in these sessions around integration of health and social care. But actually our police locally told me a month ago, one Saturday evening, they had almost all the police officers that were on duty either in A&E dealing with alcohol-related violence and things going on in the local hospital A&E department, or chasing people who had been reported as possibly going out to commit suicide, or escorting people who had a mental health problem and needed sectioning, but for whom the NHS staff were unable to deal with by themselves. And what he said was, the police resources are being diverted into the wrong end of mental health problems. And for a number of reasons I'm going to show you, I think we need to perhaps broaden some of the discussion around integration, because the impacts of failure to integrate planning and service delivery and public sector investment go way beyond healthcare systems or social care systems. One example is this, which is the idea of adverse childhood experiences, because one of the other concepts that's missing from some of this debate is the temporal dimension. The idea that over time we can identify predictable effects And we need to look at this not just as what's happening, where's the risk now, what's happening now, but actually in someone's life course from birth to death, what do we know about that, and how would that affect how we invest and change what we do? Now, there's a concept called adverse childhood experiences, which is where you say in the literature there's a whole host of things we know. If you experience them as a child, as an adult, you have consequences. And the obvious ones are, you know, there's a toxic trio where children are brought up where they have at least one parent has an alcohol, mental health or drugs problem. If you go on to if you Google adverse childhood experience, you'll see the literature on it. It's really very interesting, mainly done in the States. In Blackburn with Darwen, we've just done and published our own research on this, a big sample, 1,500 population. And what it is a questionnaire. It's on the WHO have now piloted this model questionnaire. It takes about 15-20 minutes to answer. You're asking adults what were their childhood experiences and then asking them about their adult health and other experiences. And generally, the international data suggests if you have 4 or more adverse childhood experiences out of a potential 14 that are questioned for, you can predict the rate for an adult population for which you will experience harm of different kinds, mainly health and criminal justice harm. And some of the predictability is so accurate that Kaiser Permanente in the States now are considering doing adverse childhood experience screening for their populations in order to develop early interventions to prevent later need for more expensive and often less effective interventions and treatment. So, I mean, these are the sort of figures. The one that jumps out is if you've had 4 or more adverse childhood experiences, you're more than 30 times likely to have had a sexually transmitted infection. Adverse childhood experience is highly correlated with criminal justice experience and violence. But also a wider, I mean, this is just a selection, a wider range of long-term chronic conditions. The alcohol one we think is underreported here because many of the people that have alcohol-related problems are probably dead from alcohol attributable disease and therefore don't appear in the data with using this methodology. But what the point of this is that integrated care needs us to look temporally across people's whole life course as well as just at the consequences now for adults. And it's just an interesting observation on engagement and action that there is, if you take lower turnout constituencies, we can prove a correlation even in the 20% most deprived constituencies in the UK, a correlation between depression and anxiety and voter turnout. In other words, the higher the depression and anxiety, the lower the voter turnout. Now, all these things are connected in different ways because one of our solutions around long-term conditions and demand on the health and social care system is going to be to get an engaged public more active in providing non-paid for services voluntarily for the community. And we need to understand that much broader picture around what's going on. We, in Blackburn with Darwen, decided to look at all long-term conditions and to get the best data we had, which was GP register data on the population. And this is just showing you 5-year periods going from left to right. So this is the total population, about 150,000 population. 61,000 of the population of 150,000 had at least one long-term condition. And as you'd expect, the older you get, the more long-term conditions you get. We also did a correlation tool. Most multiple long-term conditions correlate with mental health problems. So most people with a mental health problem will have another long-term condition, and that's evidenced in the literature, evidenced in our population. When we unpick it by asking a different sort of question of the data, we can ask how long would you expect to live in Blackburn with Darwen compared to the UK average with a disability-free life or with a disability? But let's start at age 16, and this is what the data is showing us. Blackburn with Darwen, very poor experience of disability and long-term conditions. The England average isn't particularly good either, and a very significant variation of disability-free life expectancy across the population for England. Partly this is the reason we aren't managing long-term conditions very well. If we look at the decay rate between what we know about who in the UK has, let's say, heart disease, we know a proportion, 5.7 million, have that as a disease, but only 2.6 million are aware of it, 2.3 million eligible for treatment, only 1.3 million getting treatment, and only 1 million compliant with treatment. That decay rate for all the long-term conditions, the top 10 long-term conditions, is actually the failure to optimally prevent, detect, treat, and manage long-term conditions is the major cause of adult social care service dependency. So this is the shared agenda. A previous speaker said he wanted public health to focus more on evaluating the outcomes of adult social care than dealing with fagging fatties or something like that. But actually obesity and smoking-related disease are one of the causes of adult social care demand. So we need to get the integration of our services need to address this issue of long-term conditions and that decay and improve service delivery across every sector on that. And of course that's also one of the causes of the A&E crisis that's going on now. I would say mental health is at the heart of it, poor mental health. But we can look at, one of the ways you would look at A&E is to say what percentage of hospital admissions were emergencies? Because those that are emergencies are those that aren't being managed well in the community. And this is just a piece of work looking at that in Blackburn with Darwen across ethnicity. We do see ethnic differences, some more significant than others, but it's clear, the long-term conditions relate to this, and our poor management of overall conditions is not good. The problem is, in the system, if the UK spends about £1,800 per head of population on hospitals, on healthcare, about just over 1,000 of that is being spent in hospitals. And we've got one of the highest hospital spends in any OECD country except the United States, which is pathologically overspending on healthcare systems. We've also got massive variation in bed numbers, even within English regions. And the problem is that investment in hospitals is not evidence-based anymore. The tragedy, of course, is that if you go onto any of the Department of Health, NHS England, or any other of the major leadership bodies in England for the healthcare system and just Google primary care strategy, you will be lucky to find anything of any significance. I'm willing to be corrected on this. But go into Australia and you'll find they've had a broad primary care strategy developing not just primary health care, primary clinical care, but a much broader biopsychosocial model looking at how to align social, political, environmental and economic determinants of illness with what goes on in a primary care service. And if we're going to make a difference to integrating action to reduce adult social care demand and improve health, we're going to need to follow the kind of experience that Australia is examples that Australia are giving us. Many of us are doing that through our health and well-being strategies. I won't go into this now, but using Marmot's approach to the life course, defining a range of actions across from childhood through adulthood to old age, and saying what integrated service delivery could we evolve that would address the biggest challenge, which is long-term conditions, which has poor mental health at its root. I'm not going to go through those because I'm just conscious of time. So I want to go just practically finish on a piece of work we're doing on that in Blackburn with Darwen. That's to create a wellbeing service. In Blackburn with Darwen, the previous PCT and the local authority both chucked £1 million into a pot and said, let's have free leisure services. And we've been evaluating the outcomes of that. We've massively increased physical activity, saved swimming pools from closing. Swimming is often the thing that those with least income will do in terms of physical activity. And basically what we're saying is we want to move that model of free leisure into a different model, a well-being service model. And we want to align a service whereby GPs could refer into a service that would basically, anybody with a long-term condition, any one of those 61,000 could get a service from a range of bodies, but that was provided as an integrated wellbeing service. And those agencies would look like this. This has been a really complex piece of work to do, and we're still discussing it. But the model would be something like a GP could refer, or you could self-refer. You would go through a gateway, and that gateway would not be like one of the criticisms of 111 and other similar models is that they provide sometimes the least skilled or less skilled people at the front end. All the experience we've got is you need the most skilled people at the front end in order to not just end up with risk-averse referrals back into high-cost clinical and other social care services. Anybody with a long-term condition would be referred into this gateway. They would then do a kind of questionnaire that would then give them access to a wide range of services that are actually, many of which are already commissioned by adult social care, by the NHS, by public health in local government, and by a range of other bodies that are nothing to do with the health and social care system: housing, employment, children and family services, benefits, welfare, debt advice. We're still working on that model, but we're trying to include a wellbeing service that offers a referral to all of those. And if you were to say, when I've talked to, early on when we were talking to clinicians about this model, they were saying, yeah, but how would it affect anything really? Really. Well, here's one example. Blackburn with Darwen had one of the highest rates of admission to hospital for asthma. Much higher than the regional average, very much higher than the national average. We're one of the worst in the countries in 2011. But actually the whole of the NHS investment in that was in secondary care, because most people were getting chronic asthma attacks, exacerbated asthma, going into hospital. The discussions were, well, let's change that system, remodel the system, move more of it into primary care. But actually even that wouldn't make a difference, because what we need is high street pharmacies, the voluntary sector, self-help community groups, schools and education, children's services within the council, and really housing as well, which is one of the prime causes of asthma exacerbation. All of those are part of the causal chain for high asthma emissions in secondary care, but all of which need to be part of the solution. So integrated care and integrated health and social care avoidance needs to extend well beyond the health and social care systems into that much broader definition, and it needs to start where the problem starts. I'm not going to do that one. So I think finally, one of the issues is if we're talking about integrated care and delivering health and reduced adult social care dependence from the current service configuration, we need to think of it much more broadly in terms of what are the public policy consequences of, what are the consequences of public policy in other areas, and what changes and interventions can we generate there? Because actually what delivers those improved outcomes are services, policies, and what the community does for itself. We mustn't fall into the elephant trap of focusing too much on services themselves. And so finally, we also need to construct a very powerful narrative. So that's one. Dave from Blackburn on the left. Charles, it isn't Charles Alessi actually, but I don't know where that particular Charles came from, but he's from Chelsea. And just following their life from a baby, age 10, age 20, age 45, and age 65, following the narrative of their life course and looking at the bottom about what could be done better if we had an integrated wellbeing service, an integrated service delivery around that. And I think that idea of getting one public sector offer for people at risk, vulnerable citizens, is really important. And that covers all the other areas as well, like the Troubled Families Programme. You know, we often talk about dysfunctional families. I think one of our challenges is it's actually the state and the way we provide services that's dysfunctional, not the people in the community who are vulnerable. And you only have to open those curtains and see how dysfunctional the health and social care system is. What we need to do is get a single public sector offer available for the community to deal with some of our biggest challenges. Thank you.
So, we've got time. Yes, very good. Have we got a couple of questions for Dr. Harrison before we end this session? I can see the lady there. Can't. Is the microphone? What's the microphone? There's a lady just there in the middle there. Thank you.
My background's in housing, and I'm interested in your model of the referral from the GP to the wellbeing person, who then refers. I've come across a similar thing for adult social care called local area coordination, and also recently another thing for housing called housing locality officers, and they're focusing on people in arrears. I'm just wondering, whether sort of if healthcare and housing all develop their own version of this thing, whether they might operate separately from each other, whereas actually those people should at least be forming a team together in a place, if not being the same person. So just your thoughts on different groups sort of inventing the same model.
No, you're absolutely right, and that is part of the reason why what we're trying to do is only at the state it's at, because it is quite complex. The police in Lancashire have developed a system which refers vulnerable people for whom they come across as part of their policing activity into a I forgot what it's a MASH it's called, but basically it's a central referral point for social care, police and others. And I think part of the discussion we need is how we consolidate that across the whole of public and voluntary sector, because the bit I haven't had time to say was around the alignment of what the voluntary sector is doing as well. And one of the big conversations we've had is, if we're saying health and social care systems need integrating, what challenges are we working with the voluntary and community sector to say, actually, you could be much more effective and efficient and helpful to the population you want to make a difference to if you also look at integrating, and integrating in a way that enables us to fit the systems together better. But you're right, registered social landlords have exactly the same challenges, which is most of the reasons why they have problems are people not paying rent. Most of the reasons why they're not paying rent are because they have alcohol, drugs, mental health problems. Most of those are causing antisocial behaviour, so you've got exactly the same population group. And we are the dysfunctional state trying to provide, and we just need to get our act together, but not just health and social care.
And I think that's a really important point. If we integrate health and social care and omit housing, we've lost more than we've gained, I think is part of the point you're making too. Right, one more question, then we must end this session. Thank you.
I've got a background in health and social care as well. I'm interested in your almost throwaway remark, which I think we're all observing in our populations, that basically life expectancy is increasing, almost regardless of what we do, life expectancy is increasing. I mean, surely the important thing is to try and understand why that is, and try and capture some of the key issues there, rather than try and invent another model which is supposed to do something which will probably fail anyway.
Yeah.
The issue, why are people living longer? Because actually, with all our
Well,
Interesting point.
that is a very interesting point, and one of the things we are noticing, if you look at, I mean, this is really a specifically public health question, isn't it? But one of the ways you could look at this is look at cohorts of populations and say, you know, a population born in this 30-year or 25-year, which is generation cohort, how long are they living? How long are they living? What we're seeing is we've actually seen a rise in there's a cohort called the golden cohort, which were born sometime around between 1920 and 1945. That cohort probably is going to enjoy the longest life expectancy. The cohort of young people that are born from 1980, we suspect, if their lifestyles and behaviours continue as they are, will actually die at an age younger than their parents lived. And the reason is alcohol and obesity. So we are increasing life expectancy year on year, but we're getting to a point where the current population cohort, if the population predictions we've got from the public health knowledge we have are correct, may well die before at a younger age than their parents did, in which case we'll see life expectancy stopping or going backwards, you know, the improvement. So we can't assume it will continue to improve. The reasons why that golden cohort will have lived longer than everybody else is really that they got, despite the wars and everything else, they had optimal nutrition, you know, all those broader social determinants of health improved during their life experience.
Okay, yeah, all right.
Well, we're going to,
Important debate, interesting question, interesting things, some helpful observations. Just to finally say a very big thank you to Dr. Harrison for showing us the kind of public health insight and the kind of a different kind of preventive solution. Thank you. The next speakers,